Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health.
Hello again, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and most of us have been there. You or someone you love ends up in the hospital, and suddenly there's this doctor you've never met walking into the room. They seem to know everything about your situation. They're calm, they're focused, and they're clearly in charge, but you have no idea who they are or where they came from. That doctor does have a name, and they're called a hospitalist. And today on Doc Talk, we're going to sit down with Dr. Matt Werpy, who not only works as a hospitalist here at Monument Health, but leads the entire program. So if you've ever wondered what actually happens once those hospital doors close behind you, we're going to find out right now. Dr. Werpy, thank you for coming in and doing this.
Yeah, thanks for having me.
Yeah, it's been a journey from what I understand to get you behind the microphone.
Yeah. I'm a busy guy and maybe was a little reluctant to be on a podcast, but
no, this will be fun.
I really want to make sure that people do understand what a hospitalist is and the role we play in the hospitalization of patients, particularly at Monument Health, and help people understand. I was at a national conference recently, and heard a statistic that was kind of interesting to me. And they did a study on inpatients. I can't remember exactly where it was, but they did it was over 1,000 patients. They asked them what a hospitalist was, and about 48% of them knew what that meant. So.
Well, is that a high number to you or not? To me, that seems.
I think it's pretty low.
Yeah. Okay.
And I think it just outlines why it's important to kind of talk about these things and help people understand what we do in the hospital and how we kind of impact their care.
Well, how did you get here, doctor? When you were growing up, you were in Pierre, right? Where you're kind of born and raised?
Yep, I grew up in Pierre, South Dakota.
Okay.
And then moved to Watertown in high school, Watertown, South Dakota. So I'm South Dakotan at heart.
You are.
And then from there went on and did my undergrad at North Dakota State in Fargo, North Dakota. And wasn't really sure what I wanted to do with my life at the time.
But did you know medicine was what you wanted to do? It
was. My dad was a family practice doctor in Pierre when I was growing up, so I kind of was exposed to that and kind of knew that lifestyle as a child and saw kind of the impact that he was able to have on his patients. But I also had an interest in science and ended up getting a degree in biotechnology from North Dakota State. And with a minor in chemistry, it kind of comes with the territory of doing that degree. And that includes a lot of lab work, working, on a lot of different kind of experiments, interacting with people a lot outside of the lab. And I found that I wanted more of those interactions. So one of my classmates at the time also had that kind of same realization, and a year ahead of me went and took the MCAT and applied to medical school and got accepted out in Pennsylvania. Lake Erie College of Osteopathic Medicine is where I ended up going, but he was a year ahead of me. So he said, "Man, just take the MCAT, apply," and so. That's what I did.
All right.
And got in. We ended up living together for a couple of years out there and kind of showed me the ropes. And I kind of started that journey to, being a physician. I wasn't exactly sure what I wanted to be at the time, but, was thinking some kind of primary care, whether it was family medicine or internal medicine. Right. And eventually determined that I wanted to be an internal medicine doctor. So,
all right. Well, that's quite a journey, obviously, to get to where you are.
Yeah.
But as we're getting into what we want to talk about today, and you kind of mentioned that with the statistic that you heard when you started the show, most people have never heard the word hospitalist before they actually need one.
Right.
So let's start very simple. How would you explain to someone who's never encountered that word before what it means?
Yeah. So a hospitalist is a physician that primarily cares for patients inside the hospital and coordinates that care from admission to discharge. So that's really our scope of practice is taking care of the acutely hospitalized patient from the time they're admitted to the hospital to the time they're discharged. And during that time frame, we're kind of the quarterback for the care that's provided. So we're the person that kind of holds it all together. So if they need, a specialist, let's say they present with a cardiac kind of issue, we'll connect them with the cardiologist. Now, a lot of that work we do on our own until a specialist is required. So some things we can handle ourselves. We're kind of more generalist as opposed to very specialized. So we can handle, all the things that patients are hospitalized for. Typically, any kind of acute system organ failure or organ system failures. So, heart failure, an acute kind of lung disease or decompensation, kidneys, GI, all those kind of different presentations that require people to be hospitalized, we can manage those pretty much primarily. Now, when the needs of the patient outpace our ability to provide that care, and typically becomes with either super rare conditions or things that require procedures or further kind of intervention to correct, that's when we engage our specialists. So we've got specialists here at Monument Health that are outstanding. Our cardiology service, we work quite closely with them on patients that present with the various kind of cardiac conditions, pulmonology, just working through all the organ systems. There's certain things that they do that they're trained to do that one person can't be trained to do all those things. And so we connect our patients to those specialists when required and outpacing kind of our training or ability to intervene. So,
well, saying quarterback, I think, is a very good term to help explain to what you're doing in the hospital. But I think the one question people listening to what you've just said right now popping into their mind is like, well, I have a family medicine doctor. Where is that doctor when I'm in the hospital, right?
Right, and that's what really kind of initiated the transition to hospital medicine doctors. For a long time, the family medicine physician or even internal medicine physician that was your primary care doctor had the ability to continue to see patients both in the outpatient setting and in the inpatient setting. Over time, the kind of demands of the medical system as we've constructed it in the United States has really created an inability for that physician to practice both outside the hospital and inside the hospital. The other thing that's kind of evolved over that time is the complexity of illness. We've made a lot of medical advances, so people are living longer, but they're living with more chronic conditions. And so the acuity of those chronic conditions all combined with a decompensation maybe of one of those systems or one of those problems creates a really difficult scenario for one physician to be able to do it all. So, you got a outpatient doctor seeing 20 or 30 patients a day. When do they have time to come and see their really sick patient in the hospital that's got multiple medical problems and then be there consistently enough to intervene and correct problems as they come, whether there's urgent or emergent things happening throughout the hospital stay? When they're seeing 20 patients in clinic, it's really hard to be in both places at once. Okay.
Well, when someone gets admitted to the hospital, like you've just obviously mentioned, there's a lot going on behind the scenes when they're there.
Right.
A lot of it that patients and families never really see. So are there things that you wish personally more people knew about as a hospitalist while you're there?
I think what I would just try to communicate to folks is as I mentioned, we're kind of responsible from that time from admission to discharge, but we're coordinating that care with a lot of different people, a lot of different teams. That includes the ED physician that you saw when you came into the emergency department, all the way to the back end where we discharge, and we're setting things up for you to discharge back to or transition back to the care of your primary care physician.
Yeah.
We're connecting all those different threads, all the things that happen during the hospital stay. We're ensuring you have follow-up as you leave the hospital with either your primary care physician or maybe one of the specialists that you engaged with during the hospital stay to make that transition a more seamless transition.
Well, I can't imagine what your day must be like then. When you must look at a list of people that are there and think, okay, I'm going to see this, I'm going to see this one, I'm going to see this one. They're all presenting with different things.
Yep.
How do you keep that straight?
Well, I think that's what draws people to hospital medicine is the kind of the variety of presentations, the variety of diseases we're trained to deal with, and it keeps it really interesting for folks. And I think that one of the big decision points for somebody that trained in either family medicine or internal medicine, most of our docs, the majority of our docs are internal medicine trained, but we do have some family medicine trained physicians as well. And there's a kind of a decision point as you're coming out of residency. Do I want to be primarily practicing in an outpatient setting, or do I want to practice in an inpatient setting? Those two worlds are getting very different. It's hard to do both, as we kind of discussed. And, just understanding of the treatments or the assessments, the diagnostics that are very different in those two settings. And I think the complexity and the variety of the presentations on the inpatient side really draw a certain type of physician that wants to be a hospitalist. And so that's kind of, I think, one of the bigger differences between the reality now and in outpatient versus inpatient is just the complexity of it and the training required to do that well.
Well, let's talk a little bit about your team too, because Monument is now kind of building a hospitalist team of employed physicians rather than the travel doctors, I think, which did that really come out of COVID? Were the travel or was?
I'll kind of give you a history of our
please.
group and then my involvement with it. The term, I think we talked about this a little bit, but the term hospitalist was coined back in 1996. So there was a New England Journal of Medicine article that came out describing this new identity or new specialty of hospitalist. They kind of coined the phrase then. That was in 1996. It took until 2004 for that to kind of take root in Rapid City. And a lot of things, it kind of came in from the coast, as
how we do most things out here,
as things tend to do. But in 2004, here in Rapid City, the leadership of the hospital and for various medicine groups within Rapid City decided that they were going to go this route. So in 2004. The hospitalist group, as we know it now, started with 4 physicians, and they practiced primarily inpatient. I think some of them still did some other work outside the hospital, but their main practice was inpatient. Fast forward to today, 2026, we now have 56 physicians working as hospitalists at Rapid City Hospital. So that is the evolution of hospital medicine here locally. Kind of reflects what happened across the country as well. Is the fastest growing specialty in the United States. So over that same time period, you saw that same kind of growth across the country. And so I trained at the University of Minnesota. I did my residency there in internal medicine from 2010 to 2013. And during that time frame, my residency had kind of a unique pathway system. There's various different pathways, but one of them was you can take a hospital medicine pathway. So you start your residency with your intern year, and about halfway through, you can choose one of these tracks to kind of develop your career for. So I chose hospital medicine, and so I got a lot of experiences within my residency that prepared me to be specifically practicing hospital medicine. And it was, there were a lot of things that I learned in that residency that prepared me for kind of a future career in that setting. So I finished that in 2013, and then I went and practiced in my hometown, Pierre, South Dakota, for about 3 years, and then was looking for a different kind of practice setting. Smaller hospital, there's a lot. You're kind of on your own and working a lot of hours, and I wanted a little bit different kind of work-life balance, and saw that a larger group could provide, a little bit more of a balance. So I started looking around, saw the hospital medicine program in Rapid City. It was growing at the time, back in 2016, but there were still some challenges within the group. And particularly the locum utilization you referred to.
Right.
So people that travel from other places to provide care in Rapid City. And so when I started with the group in 2016, about half of our physicians that were covering the hospital were locum providers. So I practiced for about a year in Rapid City, and then the medical director that recruited me to Rapid City left the group. And so we were looking for a new medical director. And in 2017, I wasn't necessarily hoping to become the medical director, but I wanted to be clear that, I had interest in leadership and leading a group. And I must have interviewed well because they gave me the job.
That's
they kind
all
of
that
called
matters.
my bluff is what I say.
Yeah, there you go.
So starting in 2017, I became the medical director. So I guess 9 years ago now,
Right.
going on 10.
Do you feel there's enough hospitalists in Rapid City, or can there always be more?
I'll describe kind of what happened in that trajectory
Okay.
from 2017 to now. In 2017, the group had 28 physicians, and as I mentioned, today we have 56. So we continued to grow from that time I took over, and we were able to take that locum utilization from about, it is around 50% down to right now it's 1% to 2%.
Wow.
And how we use those traveling physicians is to kind of offset acute demands on our coverage. So we have maternity and paternity leaves within Monument Health, which allow our physicians to be off from anywhere to 2 to 3 months. Trying to take that burden on with existing physician employment is difficult, right? And so we'll have a locum cover that time period until they get back and kind of return to their practice. So that's primarily how we utilize those locums now. The physicians I have engaged as locum physicians, there's a couple of them that have been here at Rapid City Hospital longer than I have. So they're like employed docs. They've been consistently coming here. They just never wanted to jump and become fully employed.
Right.
And so their practice within Rapid City may kind of wax and wane. We may have more need for them and then maybe less month to month. But those are essentially employed docs that
It's the winters, isn't it?
Well,
Is it that's what scared them away?
Sometimes it's
or what's-
winters. Sometimes it's their ability to maybe take a month or two off at a time if they like to do that. Some folks like the tax advantages of being employed differently, but others like the benefits of a stable kind of employment with benefits and all those things. And so we kind of made it easy, and actually that locum standpoint or that locum utilization is sometimes a good way for us to get new physicians. There are several physicians within our current group that came here as locums, and they enjoyed the experience. They really liked working with the group, and they've signed on as full-time docs.
Well, that's how you sell the position right there.
And
Yeah,
so it's
that's great.
it's a great way to recruit. It's almost like a tryout.
Yeah.
And for both sides, and
Right.
it's been a kind of a recruitment strategy of ours too. And I think something that allowed us to go from that kind of 50% locum utilization down to very minimal and really for acute needs when people need either FMLA or
Well, and I think that's super important. I mean, because trust obviously is a huge thing in medicine, because you're not only are you meeting patients for the very first time, but you're meeting them at quite possibly the scariest moment of their life too, right?
Yep.
So how do you and the doctors you work with your team, how do you bridge that gap so quickly? When you're coming in at that moment, having, in a lot of instances, I'm assuming, never even met these people.
That's one of the biggest challenges I think we face, is really making that connection with those patients and demonstrating, a competency and establishing trust about, like, hey, I've reviewed your chart. I have access to all the information from, hopefully, your primary care physician. If you're within our Monument Health system, and our EMR, electronic medical record, over time has grown and now contains a significant amount of clinical information that we can review and prepare before we even see the patient. We have a really good understanding of what's going on. That's really what a hospitalist is trained to do, is gather that information quickly, come up with a diagnosis as to, okay, what's going on here, what's required, or if we don't have a diagnosis, how do we get there, and then start to make a plan for treatment. But there is a unique skill set with kind of putting that information together and presenting it and connecting with the patient in a way that kind of develops a trusting relationship. I think one thing that's really helpful is if they have a primary care physician saying, I've seen all of Dr. Smith's kind of documentation over the last several years. I have a really good understanding for what's going on outside the hospital, and there's this one thing that, is acutely wrong, and I think we can deal with it, but I understand your medical history, I understand your clinical history and what we've tried and haven't tried so far, and what may be kind of behind your presenting illness this time.
I think that's really good for people to know, is that you, I'm assuming in a fair amount of instances, are also knowledgeable about that family care doctor that they see.
Yeah.
Right? I mean, so you might not have a full-on relationship with them, but you probably know at least something about them, right?
Exactly. You kind of know how you start to see some practice styles, right. and hopefully we interact. It's getting more difficult to do that when everybody's busy, but hopefully we interact at different either medical staff functions or other things. It gets really challenging when patients don't have that primary care physician. And I think more and more it's difficult to establish that, but it's really important for this approach to medicine to work really well. We need a very strong outpatient primary care kind of physician and provider network. Also, the nurse practitioners and PAs practice as primary care as well. And so having somebody that's kind of directing that outpatient care is really, really important. And so if we get a patient that presents to us that doesn't have that established or has never seen a primary care physician, we work really hard to make sure they get connected to that once they leave the hospital, because that role is extremely important for this system to work, right?
Yeah, absolutely. I mean, organizing this, it seems like it's just a monumental task to
Right.
throw it in there, but it does. And I think it's so reassuring now, having talked to you and how this works, how your team works, how everything kind of comes together. A lot of people, I think, though, too, assume that because we're kind of a regional health system, that it means limited sources in some instances. Is there something about what you have here that tends to kind of genuinely surprise people working with Monument?
I think the complexity and the number of different things that we can manage here, I think is impressive to people. And a layperson may not understand how complex some of these issues are that we treat, but certainly physicians that come to my group from other groups, they're like, we manage so much here that maybe in other places would be transferred to a big university center or a Mayo Clinic. We can manage a lot here in Rapid City, and I think that may surprise some people, particularly physicians. Like, wow, you have the ability to do a lot And that really is because of our role in the region. We have to be able to provide this, because otherwise they're getting transferred to Denver, Sioux Falls in some cases, maybe even further to like Mayo Clinic. Sometimes Billings, but they're pretty similar to us. But those are really big challenges that I think Monument Health has done a great job of saying, like, this is our role in the region, and we're going to build out our physician capacity to deal with all these different things, whether it's cardiovascular surgery, our neurointerventional teams, our GI services. Like, there's a lot we can do here that you would maybe see at a big university center that we have right here in Rapid City.
After years, Doctor, of caring for people during some of their hardest moments, what has that actually done to the way you see your own life kind of outside of the hospital?
That's a good question. The way I try to connect with my patients is, like, as you mentioned, this might be they're coming to me at like the worst time of their life, and I want to be there to not only provide my clinical expertise, but help them through the situation, help them understand what's happening, help them navigate what we have described as a pretty complex clinical system, right? Help them understand their disease state and just ease suffering in general. I want to be, as a physician, individual physician, I want to provide that for my patients. As a physician leader, I want to provide that for our region, right? And so making sure that I'm taking care of my friends and neighbors and really trying to connect on that personal level with like compassion and help them through, as you said, the most challenging time in their life. Yeah. For us physicians, we do this every day. And so sometimes it's easy to forget why we're here, and that individual connection, I think, is the really important part of it, and having that impact and easing that suffering or that acute kind of worst time of your life, and making it something that we can manage this. And sometimes, unfortunately, it doesn't go that way, but we're there to help that whatever they present with, we have physicians that can help them through that and provide that care to the region, and a lot of people in our region don't have a lot of great access to clinical care, and we're kind of that safety net for everybody, and from the entire western side of South Dakota to down into Nebraska, Wyoming, Montana, and North Dakota, we're serving that role for that area, and I think that's really important, and that's something that drives me to do what I do every day and be the physician leader to make sure that we get that to everybody that needs it.
Well, I hope that we have answered the question of that simple word now that we all know, which is what a hospitalist is. And I think you covered it very well, Doctor. And again, every time I talk to you guys from Monument, it's so reassuring to hear the commitment that you've made to a place like this and to the people that live around here, and to be in the community like you are. I think that's a huge thing. So I really want to thank you for coming in. See, this wasn't so bad. You'll come back and do it again, won't you?
Yeah, maybe. Okay.
I hope so.
No, I'd be happy to.
Wonderful.
And we can get into more detail about
absolutely.
The work we do. I also work up in Spearfish. I covered the Spearfish Hospitalist group. A little bit smaller group, a little different type of setting, but the same
still needed. Yeah.
Yep. The same the same perspective up there. It's just on a smaller scale. And I also do some work with our transfer center, ensuring that those patients from the region get the care they need at Rapid City Hospital, and we get them here in a timely manner and make sure they get connected to what they need. And
now,
sometimes that's a challenge.
Are you getting enough sleep at night? Is what I'm just making sure that you're getting rested.
I'm doing okay.
Okay, good. Dr. Matt Werpy from Monument Health, thank you very much for coming in and doing this, man. I appreciate it.
You bet. My pleasure.